Imagine a secret police force operating inside your arteries, one with the power to declare martial law, hoard resources, and lock down the entire nation in a matter of seconds. This isn't some dystopian movie. It's the Renin-Angiotensin System, and it is making life or death decisions in your patients every single day. So how do you deal with a powerful, silent government operating inside the body? Well, to control it, you first have to dismantle it. You have to know the key players. So let's break down its entire operation. Here's our game plan. We're going to break this down into 4 distinct phases. First, we'll look at the surveillance network. Then, we'll see how that surveillance can become oppression. After that, we'll cover the resistance movement. And finally, the absolutely critical rules of engagement. Let's dive in. Alright, first up, Phase 1, the surveillance network. You have to understand that this system is always watching, always monitoring the state of the nation, the body politic. It's designed to maintain order, and it all starts with one single informant. The chain of command here is incredibly swift and efficient. See, the informant cells in the kidney sense a drop in pressure and immediately release renin. Renin is the messenger. It finds a dormant agent and converts it into a coded message, angiotensin I. This coded message then travels to the lungs, where a master decoder, ACE, cracks the code and transforms it into the enforcer, angiotensin II. That's it. In that moment, a simple alert becomes an executive order. Now, this decoder, ACE, is actually a fascinating double agent. Its main job, of course, is to activate the enforcer, but it's got this clandestine side hustle. It also breaks down a local vasodilator called Bradykinin. Now, remember that dual role, because it becomes critically important when we start talking about the resistance. Once angiotensin II is activated, it executes a multi-pronged strategy with ruthless efficiency. It clamps down the streets through potent vasoconstriction, which jacks up the systemic pressure. It calls for backup from another agent, aldosterone, and it secures the supply lines by manipulating pressure right inside the kidney itself to retain fluid. And that backup agent, aldosterone, the system's meticulous supply team manager. It travels down to the kidneys and kicks off a resource hoarding protocol. It starts pulling sodium and water back into the blood, expanding the total fluid volume of the system. But, and this is key, it does this at the cost of dumping potassium. So that brings us to Phase 2. What happens when a system built for short-term crisis gets stuck in the on position? Well, that's when surveillance becomes oppression, and that's where we start to see disease. You know, a system this powerful is a total double-edged sword. When the alarms are just always ringing, that emergency response itself becomes the new chronic problem. And that leads to widespread systemic damage. In hypertension, for example, the body politic is in a state of perpetual lockdown. The streets are always clamped down, the system is overfilled with fluid, and this sustained high pressure just puts a strain on every single pipe and pathway in the nation. And in heart failure, it's even more tragic. The system's attempt to help is actually a curse. It forces the failing heart to pump against this immense resistance, while at the same time stretching its weakened walls with all that extra fluid. This creates a vicious cycle, where the so-called solution just relentlessly makes the problem worse. The kidneys in a diabetic patient also take a major hit. The enforcer strategy of squeezing the kidney's exit arteriole creates dangerously high back pressure inside those delicate filtration units. This intense pressure damages the filters, causing vital proteins to leak out, a classic hallmark of kidney failure. Okay, but we are not powerless against this regime. And this brings us to Phase 3, the resistance movement. Pharmacology gives us the tools we need to fight back and restore some balance to the body politic. So the first line of resistance is the saboteurs. These are the ACE inhibitors. They go right after the master decoder, ACE, and block it. No decoder, no enforcer. Simple. But remember that double aging status? Well, when you block ACE, you also stop it from breaking down bradykinin. This allows bradykinin to build up in the airways, and that causes that classic persistent dry cough. Now, an alternative strategy is to deploy the Barricades. These are the angiotensin receptor blockers, or ARBs. These don't stop the enforcer from being created. Instead, they just block the doors to all the target buildings. So the enforcer is still roaming the streets, but it can't get inside to execute any of its orders. It's a much more targeted approach. So let's compare them side by side, because this really nails the fundamental difference. AC inhibitors sabotage the decoder. Angiotensin II levels drop, but bradykinin levels rise, and you get the cough. ARBs just barricade the receptors. Angiotensin II levels don't change, but crucially, bradykinin is also unaffected, so no cough. There are a couple of other factions in the resistance too. You've got Renin inhibitors, which launch a preemptive strike, silencing the informant before the message is even sent. And then you have aldosterone antagonists, which create a resource blockade, going right to the end of the line to stop the supply chain manager from hoarding salt and water. And that brings us to our final and frankly our most critical phase, the rules of engagement. Knowing how to deploy these resistance tactics is one thing, but knowing when, and more importantly when not to, is everything. There are 3 warnings you must never, ever forget. First, hyperkalemia. Because these drugs disrupt the potassium dumping protocol, combining them to lead to dangerously high potassium levels. Second, renal function. In patients who rely on the enforcer to maintain their QME filtration pressure, like in bilateral renal artery stenosis, blocking the system can cause acute renal failure. And third, these drugs are teratogenic. And I can't overstate this point. These drugs are absolutely contraindicated in the second and third trimesters of pregnancy. The RAAS system is essential for proper fetal development. Interfering with it during this critical period can be catastrophic, especially for the baby's developing kidneys. So this is the fundamental question you have to ask for every single patient. Is their renin-angiotensin system acting as a necessary protector, or has it become a pathological oppressor? Understanding that distinction and knowing precisely when and how to intervene, or that isn't just pharmacology, that is the art of medicine.